androgen insensitivity syndrome. So just as a quick rapid revision, in previous module we have dealt about primary amenorrhea, right? So in primary amenorrhea in a patient with uterus absent on transvaginal sonography, okay, so there could be two differentials. One could be Mullerian agenesis, where there is going to be complete absence of the uterus because there is absence of Mullerian duct, which leads to the formation of uterus, fallopian tube, cervix and vagina. The second thing is going to be about the androgen insensitivity syndrome. Mullerian agenesis karyotype is 46XX. Androgen insensitivity syndrome is 46XY. Am I clear? Yes. So what is the main problem with androgen insensitivity syndrome? So the main problem with androgen insensitivity syndrome is that these patients are actually male, okay, because the karyotype is going to be 46XY. So since they are male, Y chromosome is present, therefore the SRY region is going to be present. So since SRY region is going to be present, the gonad is going to be testis in these patients. So similar in every other male population, the testis is going to produce Sertoli and Leydig cells of the testis. From the Leydig cells, there is going to be production of testosterone. The problem is that these patients are insensitive to the testosterone. And it is a disorder. It is an X-linked recessive disorder. This androgen insensitivity syndrome 46XY is a X-linked recessive disorder. Okay, now the syndrome can further be classified into two types. One is complete androgen insensitivity syndrome and the other is partial androgen insensitivity syndrome. Complete androgen insensitivity syndrome means there is complete resistance to the androgens or the testosterone, whereas partial means partially they have resistance to the androgens, but half of the 50% they are sensitive to the androgen, 50% they are insensitive to the androgens. Okay, so now before discussing in detail about the complete and the partial variety, it is very important to get a rapid revision about the testis. Okay, so we all know that testis has Sertoli cells and Leydig cells. Sertoli cells secrete something called as anti-Mullerian hormone or the Mullerian inhibiting substance. So this will cause regression of the Mullerian duct. So what are the remnants of Mullerian duct? They are the prostatic utricle and the appendix of the testis. Similarly, the Leydig cells will produce testosterone at about 8 weeks. So this testosterone has three functions. One is that it grows the Wolffian duct. So Wolffian duct is very important for the formation of male internal genitalia. What are the male internal genitalia? The seminal vesicles, epididymis, ejaculatory duct and the vas deferens. And this testosterone will get converted into dihydrotestosterone with the help of the enzyme 5-alpha reductase. Okay, excellent. And third thing is that this testosterone is responsible for the scrotal descent of the testis. The hormone which is responsible for the abdominal descent of the testis is the anti-Mullerian hormone. Is that clear? Okay. So now let's discuss about the complete and the partial variety of androgen insensitivity syndrome. Is that clear, everyone? Okay. So let's start with the discussion. Okay. So what do you mean by complete? Complete means there is complete resistance. Partial means partially they are resistant, partially they are sensitive. Is that clear? Okay. So now what is the karyotype? So in both cases the karyotype is going to be 46XY. Excellent. So in these patients, they are complete resistance are present, and in partial, there are partial resistance being present. So coming to the gonads, the gonad is going to be testis. Since they are Y chromosome is present, in both the cases, the gonad is going to be the testis. But how is the testis going to be? Since testosterone is very important for the scrotal descent of the testis, in these patients, since they are insensitive to the testis, irrespective of whether complete or partial, therefore, it is going to be the undescended testis. Why undescended? Because for the proper descent of the testis, testosterone is very important for the scrotal descent of the testis. So they are undescended testis. Okay, excellent. Now, coming under the Sertoli cells and the Leydig cells function. In Sertoli cells, anti-Mullerian hormone will be secreted. Yes, it will be secreted because testis is present, but it is an undescended testis. Okay, from this Sertoli cells, anti-Mullerian hormone will be secreted, and anti-Mullerian hormone will cause regression of the Mullerian duct. So, no female internal genital organ is going to be present. On the other hand, in complete androgen insensitivity syndrome, Leydig cells will produce testosterone. Yes, it will produce testosterone. But since these patients are insensitive to the testosterone, the further functions which the testosterone has to done. What are the further functions? The 3 functions or the 5 alpha. Yes, the further functions are that it will form dihydrotestosterone. Is that one function? Am I clear? One function is that testosterone gets converted into dihydrotestosterone. 5-alpha reductase is the enzyme which is responsible for that. The other function is that it causes growth of the Wolffian duct. The other function is that it causes scrotal descent of the testis. So we have further discussed that scrotal descent of the testis is not going to happen. So the gonad is going to be undescended testis. And since they are insensitive to the testosterone, therefore there is going to be no growth of the Wolffian duct. So definitely these patients will never have male internal genitals as well. Okay, and then the testosterone will never be converted into dihydrotestosterone because of the insensitivity. So therefore the external genitalia, since dihydrotestosterone is not present, it has the natural tendency to form the female external genitalia. So let us conclude here. The external genitalia is going to be a female external genitalia since it has the natural tendency to form a female external genitalia in the absence of dihydrotestosterone. When coming about internal genitalia, the Mullerian duct is going to regress because of the anti-Mullerian hormone secreted by the Sertoli cells. But the testosterone, since they are insensitive, it will never cause the growth of the Wolffian duct, which will lead to the formation of the male internal genitals. So since they are insensitive to the testosterone, there is going to be absence of the internal genitals. Am I clear here? Yes. So similarly, we'll discuss about the partial variety. When coming to the partial, here they are partially sensitive and partially resistant. So here also the gonad is going to be undescended testis. And when talking about the internal genitalia and the external genitalia, since they are partially resistant to the testosterone, partially they are sensitive. So the sensitive part will cause the growth of the Wolffian duct. But this growth of the Wolffian duct is actually going to be very partial growth. So only partial growth of the Wolffian duct is going to happen since there is partial insensitivity to the androgens. So the Wolffian duct will grow, but it will grow very partially since there is partial resistance being present. When talking about the external genitalia, in the absence of dihydrotestosterone, it will get converted into female external genitalia. But in these patients, they are only partially resistant. Partially, they are sensitive to testosterone. So when testosterone comes into action, therefore, the external genitalia is going to be a ambiguous genitalia. What is ambiguous genitalia? It is very unclear whether it is a male or a female baby because it is going to be a female external genitalia with some degree of masculinization. Why? Because is that for the proper masculinization of the male external genitalia, dihydrotestosterone is needed. But these patients are partially resistant and partially sensitive. So because of that reason, the female external genitalia, which is partially masculinized, is present in this patient. So those genitalia is known as ambiguous genitalia. Am I clear? Yes. So ideally, the patients of androgen insensitivity syndrome, irrespective of whether it is complete or partial, these patients are actually taken at birth to be female child since they have the female external genitalia despite their chromosome 46XY. Am I right? Yes. Okay, we'll discuss further now. Okay. What will happen next? Around puberty, what will happen is that the testosterone will get converted into what? Around puberty, the testosterone will get converted into estrogen with the help of the enzyme aromatase. So since the testosterone gets converted into estrogen with the help of the enzyme aromatase, estrogen will be more. So when estrogen is going to be more, therefore the breast development in these patients is going to be fully developed breast, both in complete as well as in the partial variety. The testosterone around the time of puberty is going to get converted into estrogen with the help of the enzyme aromatase. Since they get converted into estrogen, therefore the breast development is going to be fully developed breast. Fully developed breast correspond to Tanner stage 4 and 5. When coming to the pubic and the axillary hair, we all know that for the development of the breast, estrogen is very important. For the development of the pubic and the axillary hair, androgen is very important. But these patients are insensitive to the androgen. So in complete insensitivity, there is going to be no pubic and axillary hair. Whereas in partial insensitivity, there is going to be slight development of the pubic and the axillary hair. So partial insensitivity and partially they are sensitive. So because of that reason, partially they are going to have pubic and the axillary hair development, and their only early stages of development is going to be present. So they correspond to Tanner stage 1 and 2, early stages of development of the pubic and the axillary hair. Is that clear, everyone? Yes. Okay. Now, when talking about the luteinizing hormone and the follicular stimulating hormone, what is important? So we all know that Sertoli cells produce inhibin B, right? Inhibin B has a negative feedback on FSH. Similarly, testosterone produced by the Leydig cells has a negative feedback on GnRH and LH. Okay, so in these patients, how it is going to be? It is very important. Since these patients are resistant to the testosterone is present, therefore, the testosterone having a negative feedback on the LH is going to be lost. Since the negative feedback which testosterone has on LH is going to be lost, the LH level is ideally going to be increased. But the FSH level is going to be normal. Since the Sertoli cells which produce the inhibin B, and inhibin B produces a negative, inhibin B has a negative feedback on the FSH. Since inhibin B is produced in a normal, so therefore it has a normal negative feedback on the FSH. Since it has a negative feedback on FSH, FSH levels is going to be in the normal range. But the negative feedback testosterone has on LH is going to get lost, since testosterone is insensitive in this patient. So therefore LH luteinizing hormone is going to be increased due to the resistance to the testosterone, whereas the FSH is going to be normal due to the inhibin which is secreted by the Sertoli cells. Is that clear? Okay. Now, how will you manage these patients? Ideally, both complete and partial androgen insensitivity syndrome, these child are actually taken female at birth. Why they are taken female at birth? Because the external genitalia is going to be, in complete variety, it is going to be a female external genitalia. In partial variety, it is going to be ambiguous genitalia, where female external genitalia, which was partially masculinized, is going to be present. So ambiguous genitalia in partial androgen insensitivity syndrome, and female external genitalia in complete androgen insensitivity syndrome. So since it is female external genitalia, they are taken female at birth. So ideally what we can do is that we have to let the patients to be females. So what are we supposed to do? Why are you going to let the patient to be females? Since they are insensitive to the testosterone, only estrogen is present in them because they are converted around the puberty. So breast development is actually completed. Fully developed breast is there in that patient. So what you can do is that you can ideally let the patient to be female, since they have the external genitalia to be similar to female. They have the female external genitalia, female breast development, everything is there. So please let the patient to be female. So what are ideally required? Since this patient doesn't have any uterus, you can give estrogen replacement therapy. Why not progesterone? Progesterone, you have to give estrogen plus progesterone in any female with uterus is present. Because without giving progesterone, if you are going to give only estrogen to a female, it is going to cause increase in the proliferation of the uterine endometrium. So it is going to cause increase in the thickness of the uterine endometrium. That is not favorable. Okay, so any patient with uterus present, you have to give estrogen plus progesterone. You have to support the uterine endometrium with the progesterone. If at all not, it is going to cause increase in the thickness of the uterine endometrium, and it will cause endometrial hypoplasia and endometrial carcinoma as well. But in those patients similar to androgen insensitivity syndrome, where no uterus is present since there is no internal genitalia, in those patients you can give only estrogen since the uterus is absent. So give estrogen replacement therapy. One thing you can do. Second thing is that since these patients don't have vagina, because the internal genital organ is going to be absent, you can do vaginoplasty. You can create a neovagina, do a vaginoplasty. And the third thing is that since undescended testis is present in both complete as well as partial androgen insensitivity syndrome, you have to do gonadectomy. Okay, so around 16 to 18 years of age, all the breast development and the estrogen replacement therapy, everything will get completed, right? So after that age, you have to do the removal of the gonads, that is the undescended testis, which is present in both complete as well as in the partial variety of androgen insensitivity syndrome. So you are going to let the patient to actually be female, that you are giving estrogen replacement therapy since only uterus is absent, and then you are going to create a vaginal opening, vaginoplasty, and you have to remove the gonads. These gonads have to be removed as well. Okay, yes, so this is all about the androgen insensitivity syndrome. So we have discussed everything you need to learn about androgen insensitivity syndrome. These patients ideally will come to us with complaints of primary amenorrhea around the time of puberty. The patient comes with complaints of primary amenorrhea, that they haven't attained menstruation yet, but the breast development will be completed. So only when examining these patients on doing transvaginal sonography, the uterus is going to be absent in these patients, and when you do some blood investigation, serum testosterone is going to be elevated because they are only insensitive to the testosterone, but testosterone is going to be present in normal concentration. So ideally keep in mind that whenever a patient complains with primary amenorrhea, you're going to do history taking. A detailed history has to be taken, followed by examination with the patient's consent. Okay, in the examination, you're going to look for the breast development. In patients of both complete and partial androgen insensitivity syndrome, the breast development is going to correspond to Tanner stage 4 and 5. When examining the external genitalia in patients with androgen insensitivity syndrome, it is going to be a female external genitalia. And if you're going to do UPT, it is going to be negative. And only when you do the transvaginal sonography, you're going to notice that the uterus is going to be absent. Not only the uterus, the internal genitalia of a female, like uterus, fallopian tube, cervix, vagina, everything is going to be absent. At the same time, you can also visualize this undescended testis. You can come to a conclusion with the undescended testis being present. So undescended testis is present, uterus is absent, UPT is negative, breast development corresponds to Tanner stage 4 and 5, external genitalia is either ambiguous or female external genitalia. So all these corresponds to what? And serum FSH, ideally you have to do in every patient. So serum FSH is going to be normal in these patients, and when you do the testosterone estimation, testosterone is going to be present. So testosterone is going to be present in the concentration that has to be supposed to be present in a male population. So testosterone is going to be increased, but only when you do the karyotyping, you will get to know that the actual karyotype of this patient is 46XY. So 46XY karyotype in a patient with the testosterone being increased, serum FSH normal, undescended testis, uterus absent, no internal genitalia, external genitalia is going to be a female external genitalia, UPT is negative, breast development corresponds to Tanner stage 4 and 5, pubic and axillary hair, if it is going to be partially developed or absence of pubic and axillary hair, only with these things we can come to a conclusion of about whether it is a case of complete or a partial androgen insensitivity syndrome. So then you have to go with the treatment that you have to let the patient to be female, do estrogen replacement therapy, gonadectomy, and then vaginoplasty. So we have discussed everything about androgen insensitivity syndrome. Okay, so let's meet in the next interesting module. Thank you.